Hello, everyone. Welcome to the first session of the Mini Med School Bone Health Across the Ages. My name is Ann Van Heest. I am an orthopedic hand surgeon, as well as professor and vice chair of education in the Department of Orthopedic Surgery at the University of Minnesota Medical School. The Department of Orthopedic Surgery consists of nearly 100 faculty members and affiliated physicians, and we provide orthopedic care through mHealth Fairview, Health Partners, TRIA, Gillette, and Centricare. We are proud of our orthopedic surgery contributions to patient care, physician education, and cutting-edge research. We look forward to sharing our orthopedic knowledge with you over the next 3 weeks. This marks the 25th anniversary of the Mini Med School, which began in 1999. We are honored to celebrate 25 years of this remarkable program that began with a simple yet bold idea to make health sciences accessible to the broader community. To our Mini Med School audience, for those who are new and for those who are returning, we thank you for attending and embarking on a journey of lifelong learning with us. We are excited to have you here today, and we look forward to guiding you through bone health across the ages. Our first topic in this series is Growing Strong, Advances in Pediatric and Adolescent Orthopedics. We will begin with a moderated discussion followed by a Q&A session. You can submit your questions to our panelists at any time using the Q&A box, which can be found on clicking at the Q&A button at the bottom of your Zoom screen. Please note that this session is being recorded, and it will be available starting tomorrow on the Office of Academic Affairs YouTube channel. We will share the link of the recording with you by email. Today, we have the privilege of speaking with a panel of University of Minnesota Department of Orthopedic Surgery physician experts on the latest research and breakthroughs in musculoskeletal research and how this cutting-edge research has improved outcomes for young patients with bone and joint injuries. And now to introduce our panelists. I will first introduce Dr. Mahad Hassan. Dr. Hassan is an assistant professor in our department. He is an orthopedic surgeon who is fellowship trained in sports medicine and pediatric hip preservation. He practices at Regents Hospital, TRIA Orthopedic Center, Methodist Hospital, and the University of Minnesota Medical Center. He has a particular interest in hip preservation and treats patients with a wide variety of pre-arthritic hip disorders from dysplasia to impingement. Mahad, can you discuss research to advance our understanding of cartilage and its role in pediatric joint treatment?
Will do. Thank you, Ann. Hello, everyone. Thank you for taking the time to join this webinar. I'm going to talk a little bit about our understanding of cartilage, research advances, and its role in pediatric joint treatment. I'll try to kind of take a 10,000-foot view and sort of put a few blurbs here and there. And yeah, let's get started. Next slide, please. So I have no actual disclosures or conflicts of interest related to this program. Next slide, please. So these are my objectives. We'll give a brief overview, kind of in terms of cartilage as it pertains to pediatrics. Special consideration in the pediatric patients versus adults. They are not just little adults. They have their own kind of physiology, and that'll be the theme probably, I'm sure, through these other talks as well. Brief overview of cartilage from the 10,000-foot level, kind of non-operative treatment options, the current standard, and sort of where our technology has gone from there, and then future directions, which will be mostly sort of broad-based and not necessarily kind of as it pertains to device companies. Next slide, please. So, the ability of the body, tissues, and organs to regenerate after an injury depends on the level of specialization. That goes for any sort of cell type or cell line within the body. The more specialized it is, the less it can regenerate. And as it pertains to articular cartilage cells, they're highly specialized tissue. So they have a relatively poor regenerative potential as compared to other cell lines. Next slide, please. So like I said, there's not a whole lot of highly effective repair mechanisms, and it's a big problem when treating articular cartilage injuries. Historically speaking, we didn't really have a lot of options, and a lot of these patients would progress on to osteoarthritis, which is, especially if it happens when you're young, is a big problem. Next slide, please. So today, trauma is the leading cause of injuries to the articulating surfaces of large joints. I'm going to mostly talk about kind of the knee because a lot of that literature was sort of extrapolated to other joints, and it's kind of our little working lab in terms of different techniques that we've developed. Over the last 10 or 15 years, there's been an increase in sports participation and specialization, particularly in pediatric patients. And so this has worsened this problem. You've seen a higher incidence of ACL injuries, meniscus injuries, cartilage injuries in little kids that are playing year-round sports at a younger level. And by that token, there's been a lot more cartilage injuries, which can be catastrophic if left untreated. Next slide, please. So as I said, articular cartilage defects in the knee and really any joint have the potential to develop into arthritis. And, they pose a great issue to both the medical community as well as society, and at a ground level to the families of these children. So in general, operative treatment is indicated for symptomatic cartilage and osteochondral lesions, which mean are cartilage lesions with associated bony fragments, to improve symptoms and decrease the likelihood of osteoarthritis. There are a little bit of kind of exceptions to that, which I'll talk about a little bit later. Next slide, please. So special considerations in the pediatric patients versus adults. When I was kind of learning a lot about peds issues, the biggest thing people would say over and over again is they're not little people. They're physiologically very different from adults and should be treated as such. And so, a child is biologically speaking is a human being between the stages of birth and puberty. And adolescence, which is another sort of growing group, is the transitional stage between physical and psychological human development that occurs between puberty to legal adulthood. And so pediatric orthopedics kind of encompasses from birth all the way up to legal adulthood, and in some definitions, 19. Next slide, please. So as children and adolescents are physiologically growing, their regeneration potential is greater than that of the adult counterparts. That it also applies to cell lines, which are very specialized, like cartilage cells. The thing is, though, as we become adults, it's not just you all of a sudden you're 20 years old and all the way up to 80 years of age, everything is the same. Our physiologic kind of potential for healing declines as we get older. So the difference between a pediatric patient and an older adult is extremely large. Next slide, please. So there are some studies, I'm not going to kind of go into the details, but there are some studies that have shown that cartilage cells, however specialized they are, do possess a reparative or chondrogenic potential that is a little bit beyond that of adults. It's still, we could kind of get into the weeds as to what, but in general, younger people, particularly ones that are growing, can heal better, which is kind of the take-home message here. Next slide, please. So what is cartilage? In its simplest form, because there's different types of cartilage. I'm talking about articular cartilage, which is the cartilage that lines the ends of bones within joints. Its main purpose is, one, to decrease friction, but also to provide a little bit of a shock absorptive potential. And there's this thing called coefficient of friction, which we talk about in material science and other kind of scientific fields. When you think about cartilage, I almost kind of look at it as ice on ice. It's extremely sort of slippery surface that allows maximal efficiency when you're using that joint. When you look at the cartilage layers, the articular cartilage layers from a histologic standpoint, they're different layers. And the way I would kind of look at this is the superficial zone, its structure is organized kind of parallel to the joint, so resist more shear. If you go down to the deep zone and kind of going into the transitional zone, it's more of perpendicular and offers more of a absorptive or shock absorptive quality. About 65% of it by mass of this into all of this is water, because it's a combination of an extracellular matrix or kind of a series of molecules, water, and then the cells. Next slide, please. So in terms of cartilage injuries, in addition to a good history and physical, as well as x-rays, MRI remains our gold standard for diagnosing articular cartilage issues for the knee and really any joint. And that technology has really improved, which if you look at historically speaking, when our technology wasn't as good, a lot of these things went underdiagnosed or undiagnosed. Next slide, please. So whenever we think about things in medicine, particularly in surgery, we always divide things between surgical options and non-operative options. And we always try to start with the non-operative options first. Uh, it's generally recommended to treat children and adolescents, particularly those with open growth plates and stable cartilage issues. So if something is unstable, it's probably not going to heal, and so you would kind of be more apt to do surgery there. But typically, by approximately 3 months, that number tends to vary depending on practice. Um, Unstable cartilage issues or failure of non-operative management is an indication for surgery. Next slide, please. So these are kind of the options that we have today in terms of treating cartilage issues. And the way you can kind of divide them is by, if you want to look at it one way, is kind of square or the surface area of whatever the injury is. And so some people throw out different numbers. You can use 2 by 2 centimeters. You can use that as a number that we use. If it's smaller than that, you can do microfracture, depending on kind of what it is, and osteochondral autograft transplantation. If it's larger than that, then you would kind of move on to the other two, consisting of osteochondral allograft transplantation and autologous chondrocyte implantation, which I'll talk about a little bit. Next slide, please. So microfracture is kind of the kind of the least complicated form of cartilage preservation, and its goal is to essentially what it is you're drilling through the lesion or maybe even drilling behind it, and allowing bone marrow or healing elements to get to it. And I kind of look at the bone underneath the cartilage as sort of the root system. So this is a way of kind of aerating your lawn, if you want to look at it that way. You can do this on a lot of cartilage issues. Some don't tolerate it as much as others, especially if there's issues with the bone underneath. It may not necessarily to work as well. This is something that's been used quite frequently. If you want to think about somebody famous that had this, Kobe Bryant had microfracture surgery when he went to Colorado many years ago. Next slide, please. So the second kind of option for smaller lesions is osteochondral autograft transplantation. I kind of look at it as, you're taking from a donor site that may not necessarily be articulating or weight bearing or in use, taking little dowels or sort of cylinders of cartilage and bone underneath and filling in a defect that you have, right? By that token, you only have a limited amount of tissue to take, right? So you have a little bit of what we call donor site morbidity, where you can't just take a ton of tissue and then put it where the cartilage issue is. So typically this is reserved for smaller lesions. And the good thing about this is that you're taking live cartilage and it's bone underneath that allows it to kind of heal to bone wherever the lesion is. And so this is kind of putting in live cartilage cells with its root system to where the issue is. Next slide, please. As you get to a larger sort of defect where you're limited in how much tissue you can take, you can use cadaver tissue. Typically, you want fresh frozen cadaver tissue. If you've had it processed in any sort of material to prolong it, like formaldehyde or anything of that sort, you can't use it anymore. It has to be living tissue, and you can take a donor tissue of someone that's no longer with us, size match it, find the exact kind of area where you're missing cartilage, taking that and then putting it in the person. You can also augment this with what we call biologics. So one of them is platelet-rich plasma. You take the patient's blood, you spin it to its healing elements, and then you kind of inject that on the bone where in the graft that you're putting in. Next slide, please. I'd argue sort of kind of newest and sort of highest tech option is autologous chondrocyte implantation. which is this is a sort of a procedure where you take living cartilage cells, right? You send it to a lab, you grow it, and then you come back later and you inject it into the patient's defect. You usually have a scaffolding there. It's either, a synthetic scaffolding, or you can even use what's called the periosteum, where it's the patient's the tissue that covers the bone. And so this is not limited by size, but and so you can do this as well. There's a little bit more intricacies in terms of whether the bone is intact underneath and things of that sort. But this is kind of what we do in 2024 for cartilage issues. Next slide, please. So, where are our future directions? I think that technology is increasing at a rapid rate. In orthopedics, joint replacement, I'd say, is probably a little bit further ahead than joint preservation. But I think where we're kind of going is seeing if we can utilize stem cells, right? Cartilage cells are very specialized. They've already sort of kind of differentiated or sort of developed into what they are. The stem cells are kind of the most basic kind of type of cell that can presumably develop into anything, and maybe seeing if we can use that to regenerate lost tissue. There's other industry-driven kind of techniques which I won't really talk about. I think that the holy grail is trying to figure out a way to synthetically generate tissue that we can use to heal damaged tissue. And so that goes for both adults and children. And so we still have a long ways to go there, but this is kind of where we're at right now. And a lot of this has been kind of developed with in the lab, and then applied to the clinic. Next slide, please. So thanks everyone. I'm looking forward to being part of this webinar, and I'm happy to answer any questions at the end.
Thank you, Mahad, for that great update on cartilage research and treatment. Certainly not only for pediatrics, but for adult, if we could halt that degeneration and aging process, that would be the holy grail. All right, so our second speaker tonight is Dr. Mark Tompkins. Dr. Tompkins is an associate professor in the Department of Orthopedic Surgery. He practices at Gillette Children's Specialty Healthcare, TRIA Orthopedic Center, and the University of Minnesota Medical Center. He is fellowship trained in sports medicine, and that includes knee repair and reconstruction, shoulder repair and reconstruction, cartilage injuries, and sports-related ankle and elbow injuries. Mark, can you discuss with us pediatric sports injuries and prevention and treatment?
Yeah, thanks very much, Ann, and thanks very much to the organizers. I'm grateful to be a part of this and spend the evening with all of you. And I get to talk about something that's near and dear to my heart, which is pediatrics, specifically in sports medicine. And it's a broad area, so we're just going to talk about knee injuries tonight. I was also asked to speak about prevention, so I will go over just a few slides at the end, but I have discussed with my partner, Eliza Arndt, who will be presenting next week. So as a little teaser for anyone who hopefully can join next week, she'll be elaborating even more on some of the prevention aspects that I'll discuss. I do not have any disclosures relevant to this discussion. And so these are the main things I'd like to talk about today. 5 main pathologies. These are the most frequent ones that we see in our pediatric orthopedic clinic. And as Ann noted, I'm fortunate to be able to practice pediatric sports medicine in a couple different environments. And these are the things that we most frequently run into. So the first is ACL injury. You can see on the MRI on the left and the illustration on the right. The ACL is a structure in the middle of the knee, and it can be ruptured. The way that typically happens, most of these injuries are actually non-contact injuries that occur during sports. And there's 2 most common mechanisms. One is a pivoting mechanism, which you see on the left of the image, and a hyperextension, sometimes deceleration also, but a hyperextension injury, which you see on the right there. My goal tonight, by the way, with each of these pathologies is basically to talk about what we understand about the mechanism of injury or how the pathology develops, and then tell you what the current treatment options are. So in ACL surgery for children, we have 3 main options. And by children, I mean specifically skeletally immature children. And the reason that's important is if we were to do an ACL reconstruction surgery like we do for adults, we will risk damaging the physis or the growth plate at the end or at the top of the bone. So the end of the femur, the thigh bone, or the top of the tibia, the lower leg bone. And as you can see in the diagram on the right, these growth plates contribute a significant amount to our overall length of the extremity or overall growth. And so if we injure those, we can have shortened limbs or significant angular deformities. So very important to try to avoid that. So we have special surgeries that we do in these patients that are still growing. The first one is a partial physeal respecting surgery. So what I mean by that is specifically on the femur. You can see in the illustration on the right that we stay outside of the growth plate. We do not cross the growth plate. In contrast, on the lower leg bone, the tibia, we do drill across, but in a very central and vertical manner. It has minimal disruption. The important thing to note, though, is we try to reserve this for patients who are roughly within 2 years of finishing their growth. So you can see the ages at the bottom there. For patients that are younger, we have a couple different options where we're going to try to avoid any drilling or anything that would potentially affect that physis. So this is an all-epiphyseal technique. This is something that is possible, and we do have specific instrumentation for this. I will tell you, however, as someone who's done this for a long time, this is a very technically difficult procedure, most importantly because even though the illustration on the right suggests there's a lot of space on the tibia, there is not. We've done some studies showing that it's almost impossible to drill even a small tunnel without affecting the physis. And so this is something that we would do in the ages that you see at the bottom there. But in my practice and my partner's practices here, this is the procedure that we tend to do in the patients that are the youngest. Something called an iliotibial band reconstruction, which is both intra-articular, meaning in the joint, and extraphyseal. And again, you can see the ages there. Sort of corollary to this is the tibial spine injury or tibial spine fracture. This is basically an avulsion of the bone and some cartilage that's attached to the ACL. It's a similar mechanism to an ACL injury. It was once thought that this is what happened in kids and not ACL tears. The reality is that both of those can happen. I'll draw your attention to the illustration on the bottom here. So the B and C types, these are the main ones that we worry about because those are the ones that become surgical. And we have a couple different ways to try to manage that. One is we can fix it with a screw if it's one good piece of bone, or we can fix it with suture that basically reattaches it to the bone. The next pathology is something called a discoid meniscus, and you can see a normal illustration of the menisci. So we have both medial and lateral. So on either side of the knee, you can see they're sort of semicircular in shape. In contrast, if you look at the discoid meniscus way on the right here, you see that there is not so much of a semicircular shape. It can be quite variable. Sometimes that entire space is filled, sometimes just a portion of the space is filled. But the point is that it is not the normal shape of the meniscus. So we think that this is a congenital variant. It used to be thought that this was something where the meniscus started like that and then portions of the meniscus would recede. There have been studies looking at babies in utero that demonstrate that already at a very early stage in development, there is a normal meniscus. So this is something that we don't fully understand as to why that meniscus ends up being more discoid in shape. So obviously no mechanism of injury here. The most common is the lateral meniscus as demonstrated in that illustration. In addition to filling that space, it also is an abnormal meniscus in terms of its attachments to the capsule most of the time. It's important to note this is actually somewhat common in the population. And for patients who have it, it's oftentimes in both knees. And so these are menisci that are more prone to having symptoms and especially to tearing. If they are not symptomatic, but for some reason picked up on imaging, as you can see on the MRI on the right, the meniscus on the medial side is triangular in shape. That's what we should also see on the lateral side, but you see the red outline showing that meniscus filling that entire space. If the meniscus is symptomatic, if it's painful or if they're getting locking, then we do what's called saucerization and or repair. So in these images here, you can see the meniscus. There's a little instrument in the bottom left, the D image. That is trimming away some of that excess meniscus. And then you can see in the bottom right, those blue sutures. That's where we've tried to stabilize the meniscus and tighten it up relative to the joint lining or the capsule. The next pathology is also something near and dear to my heart. This is called osteochondritis dissecans. You can read the wordy description that we currently use as our definition. But the main thing that you can see on the X-ray on the right is basically what happens is you end up with a piece of bone, and then there's also cartilage, which is not visualized on this image because it's an X-ray. But that bone and cartilage fragment that's pointed to with those yellow arrows can become loose and unstable, and that causes pain and other symptoms. We don't fully understand the process as to how it happens, or maybe more specifically, what are the exact insults that cause it. So there's a number of different suspected things, including microtrauma, potentially inflammatory. But I'm very fortunate to work with a multidisciplinary team at the university, including veterinarians, because this is something that happens in animals, as well as musculoskeletal radiologists. And we have been able together, as a group, been able to determine that likely this is actually starts for most patients as some type of an insult to the growth plate. It's actually a different growth plate than the one I was describing before. This is a growth plate that resides right underneath the joint cartilage that Mahad was talking about, the articular cartilage. And you can kind of see that in the illustration on the right. So this is obviously a histology slide. You can see very uniform blue cartilage that's most superficial. And then deep to that, you see lighter blue cartilage. All of that should also look uniform, but that's the growth plate. The abnormality is that lightest blue area that's kind of digging into the bone on the bottom there. And that is where that cartilage, the growth plate cartilage, has basically died. It's had some type of an injury, and that injury has died, or that cartilage has died. Just like the discoid meniscus, we think that in many of these patients who have OCD, at least 10%, maybe more, have it in both knees. Here's an illustration of some special MRI techniques and then histology. I mentioned that this occurs in animals as well. So this is an example in a pig, two different MRI techniques at the top where you can see the insult, the large black area on the left, and then the corresponding red area on the right. And then on the bottom, what you see is the cartilage. It doesn't show up real well on the bottom left, but there's an area that's a little bit discolored. And then if we zoom in on that, you see that there's a bunch of empty white spaces. That's where the cartilage, living cartilage cells should be, but they are not there because they have, again, they have died. Most likely because they've had some type of vascular insult, perhaps because of those other mechanisms. Here's an example in real life. This is a histology and imaging that comes from a 16-year-old patient of mine who had previous surgery. Unfortunately, it did not succeed in healing the OCD lesion, and the fragment, as you can see on the left there, had to be removed. And what you see in the histology is, again, normal cartilage on the surface, or the top part of this, bone kind of in the middle, and then that gray or kind of gray purple area that's denoted by the yellow arrow at the bottom. That is the area where there was dead cartilage. That what happens is that cartilage should transform into bone over time. If it does not transform into bone over time, and it covers a big enough area, then it can create a lack of structural integrity, and eventually then create a piece of bone and cartilage that can become free. That's what we have been able to demonstrate and learn from our work at the university. We have a number of different options for treating. Some of these patients can be managed non-operatively and they will heal, as you see in the MRI before and after. So on the right, the above and below MRI. If they are stable but are symptomatic, then what we do is we drill these. There's a couple different ways to do it. My preferred technique is what you see on the imaging there. So we simply drill across the fragment into the native bone, and the goal is to try to stimulate healing from the underlying bone to the OCD lesion. This is return to activity 3+ months. The next is for unstable lesions. You can see how it looks like there's kind of blistering there in those pictures. In this case, we'll actually open the knee up. We will also open up the lesion. We'll clean out all of that cartilage tissue that has died. and then we'll fill it back with good, healthy bone graft that we take from somewhere else within the patient's leg. And then we fix that with screws. Because this is more work, this takes a little bit longer time to get back to activity, around 4.5 months. In the rare circumstance where we're not able to salvage or save the OCD fragment, that is quite rare actually in our practice. We've had very high success rates of being able to get them to heal. In the chance where that's not possible, then we do something that goes back to things that Mahad was talking about. Most of the time, we end up doing what's called an osteochondral allograft transfer. So we use donor tissue, as you see in the image on the left, and fill the defect. This is a similar rehab time frame to the one before. In certain circumstances, we know that alignment also matters. And so if they're malaligned in the coronal plane, as you see on the imaging here, we will also do a concomitant surgery to try to change that alignment and offload the area where we want the OCD to heal. The last topic is perhaps the most complex, and so I really enjoy talking about this. It's patellofemoral and treating it, by the way. This is patellofemoral instability, and I want to cover all of these topics. There are many aspects to why patients have problems with their kneecap staying in place. The first thing that's important to understand is some basics on the biomechanics. So Mahad talked about cartilage. One of the interesting things about the patella is this is the thickest cartilage or one of the thickest cartilages in the knee. And that's because the patella is a sesamoid bone that helps to increase the moment arm of the extensor mechanism. And basically what I mean by that is it sees a ton of force, up to 3 to 5 times body weight. And so we need thick cartilage, but we also need the kneecap and the patellofemoral joint specifically to be well balanced. There are lots of things that go into balancing the patella and the patellofemoral joint. So you can see in the image in the bottom left there, the patella kind of sitting in the groove. So that's called the trochlea. And you can see all the different angles at which we're having to consider what we're doing from an intervention standpoint to try to make it so that the overlap or the engagement between the patella and the trochlea is as congruent and uniform as possible. I enjoy these slides because it highlights all of the different things that we think about, and this doesn't actually cover all of them. These are things that I'm going to mention here in a second. And this highlights some of the many surgeries that we do to try to address these problems. So I'm going to quickly go through them. The first of 5 main bony risk factors that we think about is something called patella alta. So you can see in this illustration how the patella or the kneecap there sits way high relative to the groove. It takes a significant amount of bending of the knee before we get that patella to be overlapping or engaging with the groove. And so for this, what we need to try to do is we need to bring the patella down. In patients who are done growing, our preferred procedure is to do a tibial tubercle distalization, meaning we take the little bony prominence at the bottom of the knee and move that down and fix it. So that pulls the kneecap down. In children who are still growing, that is not possible. So sometimes we just don't address this problem in skeletally immature kids. Sometimes we do the procedure that you see on the left, the patellar tendon shortening. The next is trochlear dysplasia, which is the trochlea is the groove, as I mentioned. And in some patients, this is just not formed correctly. You see in both of these images, you can't really see a groove. It's convex instead of being concave. So one of the options is to reshape that groove or do what's called a trochleoplasty. Most of the time in skeletally immature, that is not an option. So we have to wait until they're skeletally mature. But in certain circumstances, when it's very severe, it is potentially an option. The next of the bony risk factors is extensor malalignment. And so you can kind of see in the image on the bottom left, the center point of the groove and the center point of the extensor mechanism don't line up. And so what we can do to treat that is to, again, cut that tibial tubercle or that bony attachment and move it over. Particularly the image on the bottom left, you can see that little piece that's been cut and moved in an effort to try to line things up better. The next of the bony risk factors is something called valgus, which basically means knock-knee alignment. And so as in a similar way that I showed you before with OCD, we also can try to change the alignment, and that will improve the engagement or overlap between the patella and the trochlea. And the final bony thing is axial plane or rotational malalignment. So you get basically too much twisting in the bones, the femur and the tibia, and what that will do is twist the patella off relative to the trochlea and make it more easy for it to slide out of place. And so we have surgeries where we can basically cut across the bone and twist it back to the amount of twisting that we want so that everything is better lined up. And you can see a demonstration of that on the X-ray on the right. And then we also have to think about soft tissue balancing. So we want the patella to be well balanced from side to side or medial to lateral. And oftentimes on the lateral side, it becomes too tight because it doesn't have anything opposing it on the medial side. And we do what's called the lateral retinacular lengthening, where we take different layers of the soft tissues on the outside part of the kneecap and we separate them and then sew them back together in an elongated or lengthened fashion. And the final thing, or the workhorse for these patients, is something called an MPFL reconstruction. That stands for medial patellofemoral ligament, which is the ligament that runs between the patella and the femur and helps to be a check rein, basically, or helps to stabilize the patella from going too far laterally. When there is a patellofemoral instability event, usually that is torn or at least becomes insufficient, and so we have to rebuild that. We do have a technique, in fact, that myself and one of my partners have helped to develop for doing a reconstruction like this for skeletally immature kids. And so we avoid the growth plate in a similar manner to how I was describing before for the ACL, only we're drilling tunnels in a different way. So you can see where the MPFL goes there. One more time, just highlight that there are lots of different things that we think about here. And finally, I want to talk a little bit about prevention. So I think the key thing for prevention is physical therapy and to understand faulty biomechanics that can lead or at least put these problems more at risk. So places or pathologies in which we can intervene include the ACL and tibial spine injuries as well as patellofemoral instability. Unfortunately, for the discoid meniscus and the OCD, we do not have great prevention strategies. So one of the most common things is that is a problem from a biomechanics standpoint is dynamic knee valgus, or basically the knees falling into a knock-knee position. As I illustrated before, sometimes that's just the way they're built, but sometimes that's actually happening from a biomechanical standpoint, and we want to try to correct that, as that will help to prevent. Even a more severe situation is what you see on the left. So not only do you have the dynamic valgus or functional valgus where that knee is bent in, but you also have some rotation. So you can see how the left leg there is kind of rotating in. And then if you look at the pelvis, you can see how the right hip is dropped. In contrast, on the left, you can see all of those things corrected, where everything's kind of on the left side lined up nicely. Everything's right over the foot. And then it's also important to look from the side view. And what you can see here on the left is where there is excessive anterior knee excursion. And what that does is causes significant loading to the patellofemoral joint instead of distributing the forces more evenly throughout the remainder of the knee. In contrast, on the right, when we have good engagement of the muscles, for example, you can see the hamstrings really firing nicely in this patient, then we get much more even distribution of forces throughout the knee, and therefore less force on the patellofemoral joint, less likely for it to come out of place, or less forces on the ACL, and therefore less likely for it to tear or the tibial spine to fracture. With that, say thank you very much, and look forward to the discussion at the end.
Great. Thank you, Mark. And thanks for really highlighting the respect that we have to pay to the growth plates and how the growth plates really affect the type of surgery that we recommend and the techniques in doing that. So it is now my pleasure to introduce Dr. Emmeline Sechrist. Dr. Sechrist is a fellowship-trained pediatric orthopedic surgeon. She is an assistant professor in the Department of Orthopedic Surgery at the University of Minnesota. She practices at Gillette Children's Specialty Healthcare and was recently named to our Minneapolis-St. Paul 2024 Rising Stars Top Doctors list. Her expertise includes treating orthopedic conditions such as limb reconstruction, trauma, fractures, hip dysplasia in the pediatric population. Emmeline, can you discuss with us advances in pediatric trauma?
Yes, thank you, Anne, and thank you everybody for being here tonight. This is one of my favorite topics, is the trauma patient. And this is a pretty broad topic, so we're going to be touching on mainly three things that have really advanced over the last couple of years. So I have no disclosures. So a couple of our objectives for tonight. The first thing is we're going to talk about how kids heal and how that process is so important to the growing bone and how we treat things, as well as some new technology that has come across over the last couple of years and how we are treating our children with young femur fractures. I also want you guys to understand how our treatment of wrist fractures has changed into more non-operative treatment, as well as how we're utilizing some adult surgical techniques in our more adolescent population. So this is not a common patient to show up into my clinic, and most parents come in with a disc with x-rays, and they're saying to me, Dr. Seegers, how are these going to heal? So we have a 12-year-old here on the left with a growth plate injury to the wrist. We have an 11-year-old with a proximal humerus fracture, so an upper arm bone fracture. We have another 12-year-old with a clavicle fracture, as well as a 7-week-old who had some birth trauma and that ended up in a humerus fracture. And what you'll see is as these children continue their follow-up with me, is that with the 12-year-old about a year out, you cannot tell that there was ever even a fracture there. In our 11-year-old, about 6 months out, the fracture has remodeled and changed. In our 12-year-old clavicle fracture, our collarbone fracture, 4 months out, can't even tell the fracture was there. Same with our 7-week-old. So how does this actually happen? It's called remodeling, and it's very important in the way I treat fractures and how kids go on to heal and change their bone. So how does a broken bone heal? There's 3 main phases. The first phase is called the inflammatory phase, and that happens pretty much immediately after somebody breaks their bone. And what will happen is that blood will come to the area and a blood clot will form there. It's called a hematoma. And that will bring a lot of good cells to the area that will help to go on to heal that bone. This is what also happens when you kind of see the swelling on the outside of the body, and the leg or the arm will start to get larger. It is all of that blood that's then coming to the area. Now, the reparative stage starts after the inflammatory stage. And in that stage, it takes about 2 to 3 months, and new soft bone is formed. That's called callus. It's not very strong, and it does provide some temporary stabilization as well as some more scaffolding that can then become mature bone in the future. Now, when we can start to see this on x-ray in a pediatric patient is about 12 days after fracture. So we'll start to see a little bit of elevation of the periosteum. We'll talk about that a little bit later, and Dr. Tompkins also alluded to that. And what we'll see is as the children then goes into the remodeling stage, over months and even sometimes years in some of our patients, is that provisional soft callus will then become new bone, and it'll become hard bone. And in the process of what's called osteogenesis, so we have osteoclasts, which break down bone, and osteoblasts, which build bone. They will kind of go between the two, and the bone will kind of break down and reform, and that provisional callus will then become a little bit more rigid and will form more new normal bone. This we can start to see on x-ray at about day 30 to day 45 in the pediatric population. So how exactly does remodeling happen? Well, it happens through 2 different processes. One is kind of through angulation and one is through length. Now, about most of our changing of the bone will occur at the physis. That's the growth plate. About 75% occurs there. And then the remainder will occur at the diaphysis, which is the thin part of the bone, more towards the center. And what we'll see is that right here, this is called the concavity of the bone, is that we will stimulate more bone growth on the concavity of the bone than on the convexity of the bone. And as that stimulation increases and new bone is formed, the growth plate will then continue to shift and will actually then grow straight and will align as it normally did before the fracture. Now we can also look at length. So anytime a fracture occurs, this stimulates growth. All of the cells in that hematoma and that blood clot come to the area, and then this will actually make the bone grow longer. A really great example of this is in femur fractures. So this is a patient of mine, maybe 19-month-old, and they had a femur fracture here seen on this lateral side view x-ray. And you can see that the bone is slightly short, maybe about 1 centimeter to 1.5 centimeters. And what we can see is after treatment, this is only about 8 months after the original injury, is that bone has now completely healed and the length is actually catching up to the other side. So we usually check alignment films on these kids, and we'll see if that femur fracture is now then equal to the contralateral lower extremity. Usually it is, and sometimes it actually even overgrows because kids have so much healing potential. Now, the periosteum is another really important part of the bone in our pediatric population. So this is a fibrinous sheath that basically surrounds the bone. When I talk to parents, I mainly say it's kind of an encasing along a sausage. It's very thin, especially in the adult population, but in our pediatric population, it is extremely thick. And with that thickness comes increased vascularity. With increased vascularity comes more blood to the site, which then helps to change and heal the fracture, as well as a little bit of increased stability. So the bone is stronger immediately after fracture because of that thicker periosteum. Now, does the location of the fracture affect remodeling? It does. So this is a schematic of a femur here, and we can see the physis, which is the growth plate at the top and the bottom of the bone. And then we have the metaphysis, which is kind of above the physis, and the epiphysis, which is below the physis, depending on where you're looking. And then we also have the diaphysis, which is the more thin, narrow part of the bone that's located in the middle. Now, when we have fractures at the metaphysis, this is an area that is very close to the physis, which means there's a lot of blood supply. It is very vascular. Osteogenesis, so the osteoclasts and osteoblasts, are very active there. So any fractures that occur in this area or this area have an increased remodeling potential. Now, any fractures in the diaphysis, this is a more avascular area. So again, periosteum is a little bit thinner, further away from the physis here. So the osteogenesis is a little bit more dormant. So we have a little bit less remodeling potential here as compared to the metaphysis at the end part of the bone. Now, does it differ between the upper extremity and the lower extremity? It actually does. So when we look at our proximal humerus, so the upper part of the humerus, as well as the distal radius, so the wrist area, that is where most of the longitudinal growth of the limb comes from. So 80% of the humerus growth comes from this growth plate up at the top, and 75% of the radius comes from down at the wrist. Now, because that area has so much growth potential, there is more remodeling potential in that location. We see a lot less remodeling potential at the elbow, and you can see that. The distal humerus only has 20% of longitudinal growth of the arm, so it's less able to change and therefore does require surgery more often. Now, with the lower extremity, that doesn't change as much as the upper extremity. Most of our remodeling we'll see along the distal femur and the proximal tibia. This is where most of the growth of the limb is coming from. Dr. Tompkins also talked about that when he was talking about ACL reconstruction. So we see most of the growth, 70% of this femur growth comes from here. So again, there's a little bit more remodeling potential at the knee, but much less than the upper extremity. Now, does age make a difference? It does. So we've got our little 4-year-old over here with a cast on, kind of rocking it, loving her cast. She's able to change her bone a little bit more than the adolescent over here, who has less growing to do. Now, this is not an uncommon story in my clinic. So we have a 6-year-old boy fall off the monkey bars. I always tell parents, keep them off monkey bars and trampolines, and you'll take off most of pediatric injuries out of the picture. So he was happy going across the monkey bars, and unfortunately he fell. And we can see he has this distal radius and distal ulna fracture. Now, in the AP view, it's not that displaced. It's a little bit angulated, so off to the side. But in the lateral view, you can see it's very short. So this portion of the bone here should actually be on top. And so it's about 1.5 centimeters to about 2 centimeters short. So how did we previously address this injury 2 to 3 years ago? Well, kid would come into the emergency department and we would give them conscious sedation. So our emergency department physicians usually give them something called ketamine, and it makes the child go to sleep, essentially. They're there. They don't need to be intubated, anything like that, but they just don't remember the incident, and it actually causes their muscles to be a little bit more lax so we can then perform a reduction. Now, unfortunately, with conscious sedation, there are a few complications. It can result in hypotension, so low blood pressure. Kids can vomit, and then kids can aspirate on that vomit. Now, once they're sedated, we then reduce and cast the fracture. So we take the arm, we basically put it where it should go, and we take out all that shortening, and then we put it into a cast. Now, unfortunately, this does require increased staffing. So this requires a person from the orthopedics team, the emergency department, a nurse, a respiratory therapist, usually some sort of casting tech. And so there's a lot of people that go into making this happen. Because of this, it increases the length of stay in the emergency department as well as the total cost to the patient and their family. So here's an example of the fracture. You can see a wrist fracture here at the radius and the ulna. It's pretty short, very angulated, and this child then had a reduction. So the bones line up perfectly. It's in a cast. This child's going to do great. Now, what are we doing now? We're actually not reducing these in the emergency department. So we're not giving them any conscious sedation. We'll give them a little bit of Valium or some pain medication, and we'll apply a cast in situ. That basically means that we will try to improve some of that angulation, but we are not trying to improve shortening at all. We basically are leaving them where they're at. So this is our little 6-year-old who is on the monkey bars. So again, you can see that fracture is very short. We apply this nice cast. Again, we improve the angulation, but again, this fracture is still very short, and we know that over time, this is going to do just fine. Now, are the outcomes the same between the two groups? Yes, they are. This is a study that we reference a lot. It was in Hawaii, and all of the children that had in situ cast fixation had full range of motion and grip strength at final follow-up, which means they were able to go back to all of their normal activities. Now, there were no non-unions, which means the bone healing in a not great position. Non-unions, which means the bone not healing, malunions, which means the bone healing in a not great position, and any sort of refractures. There was also minimal angulation of the bone at final follow-up. In addition, all of the parents were satisfied with their treatment, so they were fine not being reduced, and they did note that there were substantial cost savings in the emergency department as well as final follow-up. Now, because of this study, we're actually involved in what's called the DRIFT study. So it's 20 sites across North America, mostly in the United States and a couple in Canada. And it is a multi-centered prospective randomized trial. The Hawaii study was a retrospective trial, and this is just a higher quality of evidence, basically. And so when children come to the emergency department, they are placed in one of two groups. One will receive a reduction in a cast, and the other will receive no reduction and will be placed into a cast as well. And we're looking at the functional outcomes between these two groups. So we're going to be determining, does a reduction make a difference and result in superior function at 1 year's time? This has been going on for a couple of years, and we're still enrolling patients at our site. So did our patients fracture remodel? You've seen the injury film, you've seen the 1 week film, maybe you have a couple of non-believers out there, but at 5 weeks, this is all of that new callus that we talked about at the beginning of the talk. And then what we can see at 6 months, you can barely even see that he had a fracture. So this is another common story. A little 2-year-old girl was at the top of the slide, was really excited to go down it, and unfortunately she fell off. And what you can see is she has this mid-shaft femur fracture. So she has a little bit of shortening of the bone, as well as some rotational malalignment. Now, what was our previous treatment for this injury? Well, this has probably changed the most over the last year to a year and a half, but we would be placing kids in spica casts. Now, if any of you know of anybody who's been in a spica cast, they are a bear to take care of. So it basically goes up to the nipple line. It goes down the leg that's injured, and then half of the leg of the uninjured side. It is heavy. Kids don't like them, and the kids are difficult to take care of. Main issues with spica casts are, one, to put these on, we actually have to sedate children. So we have to take them to the operating room, put them completely to sleep because we have to put them on a special table. Now, in addition, most of these casts do need some adjustment at some point in time. So they might need to have a cut placed to better align the bone, or more padding placed if the child is having any sort of irritation in the cast. In addition, you can see hygiene is probably pretty tough for this family. They have to have a diaper in here. It's very difficult keeping the skin clean and dry. And we actually see skin complications in up to 28% of these children because feces and urine gets on the skin and can cause urine burns and other issues, which you can see in this child here who was in a spica cast for a while. And all of these raised kind of papules are where the urine touched the skin and then is now an irritant. So what are we doing now? It's called functional femur bracing. So our children come in who have a femur fracture. They're admitted to the hospital. They are then seen by our orthotics department, who takes measurements of their leg and their abdomen and their chest, and then makes this brace. So you can see it has a back piece of it. It's all foam on the inside, so it's very comfortable for children. And then it has a front shell. Now, kids are actually able to be bathed in this. It's much easier for hygiene purposes, able to keep kids clean and dry, and we're actually letting children walk on it a lot earlier. Now, even since we started doing this about a year and a half ago, our treatment has changed. One of the sites that I'm at is Children's Minnesota, and we are on the limited release for this brace. It is an off-the-shelf brace. So if any of you have had a cam boot in the past or a wrist brace, anything like that you get in the emergency department, this will be actually stocked in the emergency department. So children will come in, we'll put them into this brace, we'll check x-rays of their fracture, make sure that it's nicely aligned, and then they might even be able to be discharged home from the emergency department that night. It's a lot easier for families. You can see it's even a little bit less cumbersome here, and this does allow us to make a couple of adjustments if we do want to better align the femur fracture. Now, what are the benefits of the brace? Well, this doesn't require any general anesthesia to put on, so we minimize kids going to the operating room. This brace is adjustable, so you can see the child here, their femur fracture is in the middle, and unfortunately, it was malaligned. There was a lot of what we call procurvatum and a little bit of valgus. So what they did is they adjusted with just a socket wrench on the outside, and were able to create a little bit more of a valgus force, and then that was able to actually straighten out the bone. And so it's nice to be able to do that so we're not having to cut casts and adjust casts as much in the clinic. This does simplify hygiene. We're able to keep the kids clean and dry, and we're able to easily diaper them as well as put them into the bath or the shower. And as well, it does allow for some early mobility. So children are able to start walking on that. I usually tell parents, kids self-limit for pain, and when they feel comfortable walking, they will start walking. But normally it does take around 3 to 4 weeks for them to start ambulating with the brace on. So is a femur brace as good as a spica cast? It is. So this is, again, an early treatment for these, but early prospective results are showing equivalent outcomes. What we're seeing is that radiographically, all of these fractures are healing. Clinically, they have no angulation. They have nothing that we're very concerned about. And all of our families are really happy with this. I always talk to my families who go into the brace and they say, we looked at the spica cast. That looked horrible. We're much happier that our child did receive the brace. In this study, there was no difference in any shortening or angulation, and all the fractures were healed at 6 weeks. Also, there is improved car seat fitting. Most of our kids in a spica cast do need to have a rental car seat because they're too big for their car seat. But with this brace on, most of the kids can actually fit into the car seat that they have. And there's been fewer parental days off of work, meaning a lot of daycares get nervous about spica casts, so families do need to take off more days. And most of these kids in the brace were able to go back to daycare earlier. So how did our patient do? At 10 days out, you can see there's a little bit of varus angulation in through here, maybe still a little bit of shortening. This child is only 3 months out. I saw them recently, and you can see all of the healing that has happened. So most of that varus has improved. It's still in a little bit of varus, but it will continue to remodel. And what you can see is that all of this new bone has formed, and over the next year, this will continue to straighten out, and the child will continue to improve. This kid at 3 months is back on the playground doing everything that they want to do. So lastly, we have a 13-and-a-half-year-old male who fell during hockey, and this child sustained a tibia and a fibula fracture. You can see here, this is an AP, so a front view x-ray of the knee, and a lateral side view x-ray of the ankle. Same with here, just flip-flopped, a lateral of the knee and a front view x-ray of the ankle. So initially, this child was placed into a cast in the emergency department to try to treat them in a non-operative fashion. Now, unfortunately, again, like we talked about at the beginning, this is a 13-and-a-half-year-old. So this child is older. He has less remodeling potential, so less ability to change the bone. And what we can see here at the fracture site, there is actually a fair amount of shortening as well as what we call translation. So the bones are almost completely separated from each other. And we know that in this 13-and-a-half-year-old male, this isn't going to heal. So tibia fractures in adolescents are tricky to fix because, again, these kids are older and heavier, and our optimal treatment is very controversial. Now, we do have a couple of treatment options. One is close reduction and casting. So most kids do look like this with this very long leg cast on. Lots of parents don't like it because, again, it's just heavier. It's difficult for them to get around. And then we have a couple of other surgical techniques called flexible intramedullary nailing and rigid intramedullary nailing that we'll talk about. Now, close reduction and casting is just a child being placed into a cast in the emergency department. Now, unfortunately, about 21% of these kids do require a cast modification or a cast change, whether it be for a cast that's soiled or a cast that's not in appropriate alignment. And then 60% of them require over 3 months of immobilization. So that's an active teenager who wants to get back to sports, who is not walking or starts walking with a boot on, but does have to have something else. And most of these kids aren't too happy with that. Now, this is something that we can do in our casting. So we can cut a little wedge out of the cast if we have a fracture that is malaligned. So this fracture is falling into what we call varus. And so what we can do is take a little piece of the cast out, stick a little wedge in, and then that bone is straighter. Now, what we found is over the past few years, our trends in treatment are going more towards surgery. So back in 2000, only about half these kids were getting surgery, and now it's increasing to about 3/4 of kids. The other treatment option we can do is something called flexible intramedullary nailing. So there are these skinny nails here that are inserted into the tibia that then basically help to stabilize the bone. Now, our advantages is that it helps with immediate stability. So it's a little bit less finicky than a cast because it does give more stability to the bone, and it's inserted through basically little incisions about this big at the knee. The really nice thing is that it does not cross the growth plate. So this is the proximal tibial growth plate here. So it does not have any interference with any sort of growth to the top of the tibia. Now, some disadvantages include these kids can't walk on this. This does apply some stability to the bone, but unfortunately is not rigid enough to allow for immediate ambulation. And most of these kids do have to be placed into a cast for about 4 weeks just to allow enough of that immature callus to occur at the fracture site to better stabilize them. Now, in older children, like our 13-and-a-half-year-old who is playing hockey, there is a higher risk of malunion in our older, heavier children. So how are we starting to treat tibia fractures in adolescents? Is with a reamed intramedullary nail. Now, this is not a new technique. This has been used in adults for a very long time or in adolescents who have a closed growth plate. Now, where we're kind of pushing the boundaries here is that we're actually inserting these tibial nails through open growth plates. Now, one of the benefits is that it does control the fracture alignment better than a flexible nail or a cast, and it allows for immediate weight bearing. So this child is up and walking on their leg the next day after surgery. The only quote unquote problem is that it does violate the proximal tibial physis. So when we insert the nail, we have to insert it right here at the knee. So you can see this nail, both on the front view and the side view, is going through that growth plate. Now, over the past few years, there have been some limited studies that are demonstrating no significant growth arrest to the proximal tibia, but we don't have huge studies yet. This is being done in many centers across the country. I'm doing it, and in one of the trauma groups that I'm a part of, this is actually a study that we're looking at now. In the kids who I have done this in, I have noted no growth arrest or any sort of coronal malalignment. Now, how'd our patient do? So this is post-op. You can see at 4 months, there's a bunch of new bones, so new callus. Fracture's not completely healed yet, but pretty much back to most activities. And then at a year out from injury, you can see the fracture is completely healed and that proximal tibial growth plate, so you can see the line here and the line here is completely open. On his standing alignment films, there's no evidence of any discrepancy between his two legs. In addition, his overall coronal alignment, so any sort of varus or valgus, is equal to his contralateral lower extremity. So children have a high remodeling potential. It's something that we, think about when we're treating our pediatric fractures. So most of our kids can be treated non-operatively with a cast or a brace. Our advancements in bracing are minimizing anesthesia and actually making at-home care easier for parents. And surgical techniques that we'd previously been used in adults are now kind of going more towards our adolescent injuries and actually may benefit a certain population. So that's it, and I look forward to the discussion coming up soon.
Great. And thank you, Emmeline, for that PEDS trauma update. So now we'll move on to the questions submitted by our attendees. As a reminder, You can submit your questions to our panelists using the Q&A box, which is found by clicking on the Q&A button on the bottom of your Zoom screen. Now, let me also remind you that each of the panelists tonight are practicing orthopedic surgeons. And for specific patient care questions, I would remind you that clinic appointments can be made with any of these physicians to address individual concerns. So, Mahad, let's start by going back to you. One of the questions that was submitted is, why has it been so difficult to grow and implant synthetic cartilage? And then they also made the comment that their 17-year-old son had had a meniscal transplant, which was quite successful. Can you comment on that regarding a meniscal transplant and the difficulties that we've had in regenerating cartilage?
Yeah, cartilage is when I say synthetic, using kind of stem cells, not necessarily synthetic, but it's the creating something that will kind of stay and take in the joint environment is pretty hard. The environment in the joint is actually pretty toxic to cells. The joint fluid, it's pretty sort of devoid of oxygen. And so trying to kind of offset all those issues is quite tough. In terms of a meniscus transplant, that's actually really cool. I had one done 20 years ago, incidentally. And it's a little bit of a different kind of procedure. The meniscus is a different type of cartilage, has a little bit of a shock absorptive and kind of low distribution process, but you don't necessarily see it, kind of your own cells. And Dr. Tompkins maybe can also talk about this a little bit too. But you don't really see its own when you transplant a cadaverous meniscus. It's more of a structural tissue as opposed to something that's biologic like cartilage.
Mark, do you want to comment on that at all? The difference between articular cartilage and meniscal cartilage?
Yeah, thanks. Yeah, I'd love to just add to, I totally agree with what Mahad said. Hopefully not getting too much in the weeds here, but I would say there's a couple different things. So for the articular cartilage, it becomes complicated also for all the reasons Mahad said, in addition to when you look at the cartilage, under the microscope in a histologic manner, we know that not only do we have the chondrocytes, but we also have other components to the cartilage, in particular collagen. And depending upon the level that you're at, superficial or deep in the cartilage, it's oriented differently. And so the challenge is to not only just get cartilage and to even get it to implant, but also to have it actually be structurally similar to normal cartilage. In fact, I'm very fortunate to partner with a group of colleagues at the Stem Cell Institute, and we at the University of Minnesota can grow cartilage. But what we can't do is we have so far not been able to demonstrate that we can actually get that to layer in the way that we would want it. So for whatever that's worth, there's lots of people working on this. There are lots of details that make it very difficult. As far as the meniscus goes, kind of along the same lines, there are people working on developing some type of, again, like Mahad said, I wouldn't necessarily say synthetic, but a substitute. There are some options out there, some things that are actually available in Europe and not here, including trying to develop the structure and then seed that with the patient's own cells. There are 3D printing efforts that are going on to try to 3D print the meniscus. None of those things right now is clinically available because it's just not far enough along in the process. So like Mahad said, for now, from a meniscus standpoint, we try to do everything we can to save it, the patient's native meniscus, and then if we need, we'll do some kind of structural thing like transplant, allograft.
Maybe we can continue a little bit along those lines of, there are two questions about the autologous cartilage transfer. Mahad, do you mind commenting on the origin of the stem cells for the autologous cartilage transfer? And then also, could you comment on the use of the hydrogel scaffolding, whether that is still being tested and how it compares to other treatments?
Yeah, the autologous chondrocyte implantation kind of found its genesis from you take a sample of cartilage cells from the patient, and you basically multiply it in a lab, and then you inject it back into the patient, over the site where the cartilage is damaged. And you can either have it under a sort of synthetic matrix, kind of to cover it, or you can use the periosteum to cover it. There's other things you can use as well. And so that's kind of I'd say probably the most high-tech technique that we have at the moment. It still has its limits. It's good in terms of giving you sort of a biologic sort of resurfacing, but from a structural standpoint may not necessarily be as sturdy as some others, and it takes a little bit of time to heal. And so that's kind of its drawback. In terms of kind of these sort of you said hydrogel, right? In terms of these other things that we kind of use in the joint, there's some industry-driven efforts to try to kind of come up with other things like biocartilage and the like, and we're not necessarily seeing it hasn't kind of been as successful enough to warrant sort of more widespread use, especially when it comes to the high shear environment of the knee.
So when you say that the cartilage cells are harvested from the patient, where are they harvested from?
Yeah, and so when you're doing an arthroscopy, so usually this is a two-stage procedure. So typically what you do is you do an arthroscopy or another procedure to kind of survey the damage that you have. And then what you'll do is you'll take a sample of cartilage from an area that's not weight bearing. And so sometimes you can go kind of on the cartilage that's sort of in the notch where the ACL and the PCL is. You take a little bit of that sample, and then you remove it, and then you send it off to a lab to be grown. So you want to take it from an area of healthy cartilage, right? So you're not necessarily going to be looking to get that from where the area is damaged. And it also tells you an idea of how big the defect is and kind of what to do later on.
And then what's the time frame between that first surgery and when you would go back?
Yeah, it takes
Sorry,
it takes a bit of time, in a matter of uh, you know, maybe 6 weeks to months, depending on kind of the supply. I know when I was in Boston, there was a company that was kind of there that did this, and so maybe sometimes you might be able to get it back sooner, but it takes several weeks for the cartilage to grow in the lab.
So another type of cartilage is the growth plate. And Emmeline, you talked a lot about injury to the growth plate. Can you comment on, I'm sorry, I'm just looking, if a child or an adolescent shows an interest in weightlifting, is it advisable to allow them to do so, or could this cause damage to their growth plates?
That's a good question, and something that we get commonly, no matter what, in Dr. Tompkins or Dr. Hassan's office, we all get this question. And I think that weightlifting is appropriate to an extent. Now, I don't think that a 5-year-old should be weightlifting. We normally say, hey, do your normal activities of daily living, because again, the physis is an area that tension can be pulled through, and we don't want to stress the area too much. I normally say if a child is approaching that adolescent stage and they're interested in weightlifting, just start with kind of the bar, start with gentle weightlifting, 5-10 pound weights, something like that, depending on the size of the child, just to not basically stress the growing area in the kid.
And as a follow-up on that, maybe Mark, we could ask you, when we think about meniscus tears, what are the main causes in children in a very simple language? So they ask specifically, how much activity is too much for children?
I'm not sure we know how much activity is too much. Generally, it's okay for kids to be active. I think there's another question that we may come back to in a bit about kind of, overuse and early, especially as it relates to early sports specialization. So I'll maybe leave that part alone. But I think just activity in general, free play and that kind of stuff, I'm not sure that there's too much. I mean, I think kids' bodies are made to be able to move a lot. As far as the meniscus goes, I think most of the time it is some kind of sports related or at least, sports adjacent type of movement activity. So there is some trauma, there is some kind of oftentimes rotational and or impaction. type of injury that occurs to result in meniscus tears. Fortunately, meniscus tears in kids, particularly skeletally immature, is actually pretty rare. A little more common in the discoid meniscus, like I talked about, but fortunately, in skeletally immature, it's rare. In adolescents, it's more common. In adolescents, it's similar to adults, especially if it's concomitant with other injuries like ACL.
And then in follow-up on that, when you do that saucerization of the discoid meniscus, do you see an increased risk of a torn meniscus?
Well, the whole point of doing this authorization is hopefully to reduce that risk. It's really in combination with potentially a repair if there's any instability of the attachments or the capsular attachment to the meniscus. As long as that's stable, and then we do this authorization, in theory, we're reducing the risk of further tearing. That's sort of the idea behind it. And most of the time when we're in there, there's already a tear. So most of the time we're saucerizing a place where there's already a tear back to a point where there is no tear.
So it actually makes the meniscus more stable.
Hopefully, yes, that's the goal.
Emmeline, maybe you can comment a little bit. I know this wasn't specifically your topic, but there is a question about juvenile idiopathic arthritis and how that affects bone growth. Would you be able to comment on that?
So juvenile idiopathic arthritis is mainly a joint issue. So that affects, hip, knee, ankle, multiple joints, and is usually managed by our rheumatologists. Now, thinking about specific joints, some of the growth plates are actually in the joint. So it just depends on where actually the growth plate is. I'm not sure about any studies that quote growth plates as well as injury and juvenile, idiopathic arthritis. I do have a couple of kids who follow rheumatology and myself for that, and I haven't seen anything in the growing child, but I think that question would be better fielded by a rheumatologist.
Yeah, and again, I think one of the things our symposium has highlighted here tonight is the different kinds of cartilage. So we have growth plate cartilage, we have articular cartilage, we have meniscal cartilage, and we usually think of the idiopathic arthritis primarily affecting the articular cartilage. So that's a little bit different and usually has different long-term effects, but for arthritis. Mahad, you had talked a little bit about microfracture, and we have a question here saying, my understanding is that microfracturing can often lead to fibrocartilage rather than the desired hyaluronic cartilage in knees. Is there any advances towards this, or could you comment on that?
Yeah, you're exactly right. It's not exactly the actual the hyaline cartilage that we have, but it's kind of a sort of an option, right? And there's different types of drilling that you can do specifically for microfracture. The concept is you get bleeding into the site, and then it organizes itself into fibrocartilage, which is actually a similar type of cartilage to what the meniscus has. So it's not quite as good as articular hyaline cartilage, but it's better than nothing. So that's why it's in some ways it's sort of not as prevalent as it used to be. It's more of a salvage procedure these days for a lot of things where other better options can be done.
And again, talking about the different types of cartilage, Emmeline, could you comment a little bit? There's a question about the impact of dislocations on cartilage and how it's handled in the ER. How does that affect the growth plate versus how does that affect articular cartilage? What do dislocations that are reduced in the ER consist of? What are they at risk for?
So I think when we think about our main dislocations, the one I really worry about is a pediatric hip dislocation, which is a relatively rare phenomenon, but unfortunately it does happen. And when this happens, it's usually a risk for articular cartilage because it's such a high mechanism of injury to force that hip out of the socket that sometimes it can actually cause a fraying of the articular cartilage on the femoral head, so the hip joint. So usually in those kids, sometimes we reduce them in the emergency department. It depends, but usually we're taking them to the operating room to make sure that they have great sedation, the muscles are relaxed as possible. And then we're usually checking a CAT scan and usually an MRI afterwards to see if any sort of cartilage was taken off and was sheared off. And then that's when I'd be sending it, to my hip preservation partners to essentially deal with. Now, a fracture through cartilage through a physis, it's pretty rare to have a dislocation through the actual growth plate. Usually how children fracture is they go through the growth plate and it usually takes off just a touch of metaphyseal bone. And what will happen is we'll reduce them and we want to watch them long term, because what can occur is something called a physeal bar. So kids heal too much and they lay down too much bone, and it can actually cause very mature bone across the growth plate, which depending on the age of the child can cause that limb to grow shorter versus grow in a abnormal position, whether varus or valgus, depending on the limb involved. And that's when we have to say, depending on the age of the child, are we following this until skeletal maturity, or then are we actually going in and taking out that little piece of bar?
Yeah, that's probably a really good thing to mention about physeal bars and the risk of that with these growth plate injuries. Mahad, maybe we can go back to you. There was a question about when we use cadaver donors for osteochondral allografts. Is there rejection of the graft materials from the donors? Could you comment on that?
Yeah, the joint is relatively sort of well, it depends on it sometimes it might not heal into the kind of the recipient site, but rejection in terms of similar like you would reject an organ transplant doesn't necessarily happen in the knee as much. It's sort of a little bit more biologically inert tissue, and it's a little bit more immune privileged, and so you don't have to go on any sort of immune suppressants or any medications or anything of that sort as it pertains to the cartilage. So we're a little lucky from that standpoint.
Yeah, it certainly isn't like solid organ transplant, and is incorporated fairly well. Mark, we had a question about ACL injuries. There's a couple questions. One of them has to do with the female athlete, and we'll be covering that more in our session next Wednesday.
Yep.
But the other question is, why are we seeing more ACL injuries in younger and younger patients? Does it have to do with participation in sports at younger ages, or is there anything else that contributes to it?
Yeah, I saw both of those questions. So there's two kind of along the same lines. Thank you very much for asking them. I'll try not to be too much on a soapbox, but as a father of 3 children from high school to elementary school, I think this is a super important topic, and particularly in our society and some of the current societal pressures. So, and as a coach of them, I think I have a unique perspective as a provider as well as a parent. The reality is we don't have cause and effect. So we don't know whether the reason that there have been more ACL injuries is because of the early sports specialization. But most of us who are in the pediatric sports world believe that it likely is related to early sports specialization. So it's not so much necessarily that they're too active. It's that they're too active doing the same repetitive stuff all of the time. And so that they don't necessarily get the opportunity to cross train, whether that's playing a different sport, whether that's, again, free play or doing something else. And I think that hopefully over time we'll find ways to demonstrate cause and effect. I think to suffice it to say that I think if you can have kids involved in more than one thing, there are lots of sort of corollary evidence to demonstrate that that is probably a good thing. So early sports specialization, for the most part, from a physiologic and health standpoint, isn't so great. And there's also plenty of studies showing other things, mental health and long-term involvement and that kind of stuff too. As a side note, one of the things we haven't really demonstrated, so I can put it in the chat. I was fortunate to be part of a team that we looked at the Health Partners insurance database a couple years ago. So the nice part about looking at the incidence of ACL injury through something like that is that we can control the denominator and the numerator. And so we can kind of see how things are changing over time. And what we did see was that, in fact, there has been an increase in ACL injury over a 20-year period. The numbers were powerful enough to demonstrate that in adolescents. So we actually had two groups from 14 to 16, 16 to 18. That was very clear. What we were really after. And the reason we did the study in the first place was under age 14, because all of us who are in ped sports feel that we are seeing it in those kids as well. The reality is that there's still few enough ACL injuries in those kids that we were not able to clearly demonstrate it, but that may change over time. We'll have to see. So I'll put that publication in the chat if anybody's interested.
That's great. Thank you, Mark. I had a couple for you. I have for Dr. Sechrist, the child with the oblique femur fracture, the femoral shaft fracture. Will the length of that bone be affected long term?
No, so the great thing about kids, even if it is a little bit short for a period of time, is that child will then overgrow the femur fracture. And I normally check standing alignment films on my kids with femur fractures at about a year out from injury. And I just check their leg lengths and make sure that they're relatively symmetric. If they're not, I continue to follow them as they continue to remodel. But usually kind of having a femur that is short is not a problem, because we know that children will overgrow their fractures about 2 to 3 centimeters, just depending on the age of the child.
Yeah, somehow that bone is really smart, isn't it?
It is. It's the best thing about treating kids.
Can you also comment a little bit about whether there have been any complications or challenges using that new functional femur brace?
I think any time that you institute something new, there's of course challenges within a system, as you know, everybody gets used to using it. X-ray techs get used to taking new, pictures, things like that. I think one of our big challenges has been efficacy. So when kids come in, making sure that, or I should say efficiency, when kids come in, making sure that they get molded for the brace is then delivered, and we can get them discharged from the hospital within a day. I think sometimes, especially on the weekends with the brace that we currently have, it can be a little bit difficult to get them discharged within a day and then home to their families. Unfortunately, that does come with getting used to a new brace and a new way of treatment. I think as we start instituting this off-the-shelf brace, that will become a little bit easier with time.
Great, thank you. Mark, maybe we'll shift back to you and ask, what's the current thinking on weight-bearing exercises such as running and its effect on your knee and long-term arthritis?
Sorry, I realized I was muted. What I would say is what I typically tell patients, and this is more for adults, I think, there's not any evidence for kids that if they're running too much that we see clear evidence of long-term consequences. But more for adults, movement of the knee is good, as I think has probably been highlighted. I think Mahad mentioned it, that having movement actually helps to deliver the nutrients to the cartilage, for example. So movement's important. Impact is sort of somewhere in between. So impact isn't necessarily bad, but too much impact can be bad. So I think it's something where you basically want to pay attention to the knee. If it's symptomatic, probably trying to do more impact is not going to be productive in the long run. What that means for any given individual patient is really hard to say unless we're kind of following them over time, but that's a general approach.
All right, and then I think probably our last question here, maybe you could take this, Emmeline. How do you determine whether something is an accidental injury or whether it's child maltreatment?
It's a big thing that we see in the emergency department, unfortunately. And it's always tough when a kid comes in with that story. I think there's a few things that we look for. One is that is there a story behind the injury? So we have a child, a 2-year-old, who was going down the stairs, tripped and fell. Mom saw everything. Then we have a story to match the injury. It makes a lot of sense. Now, if we have a 8-month-old who's going down the stairs and fell, maybe not as likely. We always worry about femur fractures in children who are non-ambulatory, so who are not walking yet, or are younger children, so less than 3 years of age. And so we have a great, our Children's Minneapolis is our main level 1 trauma center, and we have a great child protective services group there. And anytime a femur fracture in a young child does come in, just because sometimes, that's what they're presenting with, is that we have a group of people who talk to the family. And if there's any concerns, we get what's called a skeletal survey. So it's x-rays of all the different bones to see if we see any other bones that are fractured or any other bones that are in different stages of healing, as well as just look at simple signs on the kid. Is there a lot of bruising? Is there a lot of whatever we might see? Then we will continue to work that up as, is it called non-accidental trauma?
All right. Well, I really want to thank our panelists for your time and for sharing your insights into how we are moving forward with pediatric orthopedic care. I think this has been a really great topic. I really want to thank those who are with us still, our participants in the mini med school, for joining us today. We had a lot of questions that we were able to get to, but other questions that we were unable to get to. I would encourage you that you can make appointments with any of our providers here to answer specific individual patient questions, as we primarily try to look at generalized topics in our question and answer session. So we will see you next week for the second mini med school session. That will be on sports medicine, maintaining musculoskeletal health. And then this will be at the same time next Wednesday. We have an amazing group of University of Minnesota Department of Orthopedic Surgery experts that will be discussing preventing and treating common injuries such as ACL tears, rotator cuff injuries, new insights into biomechanics and injury prevention strategies. And then our last week, we'll be moving on to the geriatric and the older population. So we look forward to continuing to follow with you with bone health across the ages. So thank you very much.